Welcome to Advances in the Assessment and Management of Multiple Sclerosis, presented by Northwestern University's Feinberg School of Medicine at NeuroSeries Live. My name is Dr. Bruce Cohen, professor in the Davey Department of Neurology and Clinical Neurosciences at Northwestern University's Feinberg School of Medicine. I'm pleased to serve as chair of this educational series. Today is the third and final segment in this series for this year. Our first live session today is called Maximizing Adherence to Disease-Modifying Therapies in Patients with MS. Following this presentation, my colleague, Dr. Patricia Coyle, professor and vice chair in the Department of Neurology at the Stony Brook University Medical Center, Stony Brook, New York, will discuss strategies for optimizing function and quality of life in MS in today's second session. I'd now like to introduce my colleague, Dr. Joy Derwenskas, who'll join me for today's first session. Dr. Derwenskas is Associate Professor of Neurology at the Northwestern University Feinberg School of Medicine. Before we get started, I'd like to remind you that today's session is a live interactive program that allows us to take your questions in real time throughout the presentation. So I'd encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. And so now, Joy, let's get started. Seem to have a little, there we go. Several years ago, I saw a 31-year-old woman with multiple sclerosis who was referred for consideration for mitoxantrone therapy. She'd been taking high-dose interferon beta for 2 years after previously failing glutaramine acetate. She'd been hospitalized 4 times in the past 2 years for steroid therapy for relapses causing leg weakness and imbalance, and had experienced incomplete recovery such that she fit the definition for worsening relapsing MS, the indication for mitoxantrone at that time. On examination, she used a scooter for mobility and had spastic paraparesis and ataxia. After a detailed discussion of the potential adverse effects of mitoxantrone, she acknowledged that she was not taking her interferon because she didn't want to take shots. When I asked her why she didn't tell her primary neurologist about this, she said that she liked him very much and she really wanted him to think well of her. She lived with family members who were supportive in her care and concerned about her health. When I asked if she had discussed her medication concerns with them, she revealed that she was squirting the interferon into the toilet and placing the empty syringes into a disposal container so that her family would not be angry with her for not taking her medication. Adherence is a problem with all medications. It's been estimated that typical adherence rates for medication are about 50%, with a wide range. In a study of 286 individuals on monotherapy for hypertension, 21% reported missing doses at least 1 day weekly on a questionnaire. However, when checked against MEMSCAP data, 42% were not adherent at or greater than this level, and 27% overall overreported their actual adherence to some degree. It's been estimated that of medication-related hospital admissions in the United States, 33 to 69% are due to poor medication adherence. Ethnicity, gender, and socioeconomic status have not been consistently associated with levels of adherence. What do we mean when we talk about adherence to a medication regimen? Medication adherence, which is synonymous with compliance, is the degree or extent of conformity to the recommendations about day-to-day treatment by the provider with respect to timing, dosage, and frequency. In clinical studies, adherence can be defined as the extent to which a patient acts in accordance with the prescribed interval and dose of a dosing regimen, and is usually reported as a percentage. Medication persistence refers to continuing the treatment for the prescribed duration. In clinical studies, persistence can be defined as the duration of time from initiation to discontinuation of therapy and can be reported either as a continuous variable by the number of days, or a dichotomous variable over a predefined time period using some threshold. Studies typically describe adherence over an interval, but vary in the criterion that they use to define non-adherence. What sort of factors affect adherence? In a Swedish study of patients on hypertensive medication, 73% had a blood pressure greater than 140/90 despite being prescribed treatment. Those individuals who were adherent cited trust in their physician, a desire to control their blood pressure, a fear of the consequences of not controlling their blood pressure, such as heart attack or stroke, the absence of any inconvenience taking their medication, and a desire to avoid symptoms of hypertension such as headaches or palpitations. Those that were non-adherent cited side effects or symptoms that they related to the medication, disliking the idea of taking medication in general, the absence of any symptoms of hypertension, a belief that the treatment was unnecessary, and the desire to avoid side effects, particularly when they might interfere with some life activities which would cause them to skip doses. And then some simply said they forgot to take the medication. Other factors may also affect adherence. In a meta-analysis of studies of adherence, depression conferred a threefold increased risk of non-adherence. The degree to which a patient understands the rationale for the treatment and expected outcomes, the complexity of treatment regimens, the impact of a treatment on their lifestyle, the side effects and their ability to manage them, the cost of the medication at an individual level, and the presence of cognitive impairment or dementia all affect adherence. Continuing monitoring by medical personnel, educational level, health beliefs, and the degree of social support are also factors which affect adherence. Dose frequency has been shown to have an influence on adherence. In a systematic review of studies that used MEMSCAP measures of adherence, once daily dosing had about 22 to 41% more adherent days than 3-time daily dosing, and 2 to 44% more adherent days than twice daily dosing. Therapeutic persistence can be difficult to maintain. In a retrospective review using a linked database among patients greater than 65 years of age who were prescribed statins and who were participating in a Medicaid or pharmacy assistance program such that the medication cost them no more than $5 per prescription, they used an outcome measure called proportion of days covered, which is similar to what we currently call MPR, or medication persistence ratio. In these individuals, they looked at the adherence defined as the degree of prescription filling within a 3-month interval, and persistence as the duration over which the patients continued to fill their statin prescriptions. The proportion that were adherent declined from 60% in the first 3 months to 32% at 120 months. The proportion that were persistent declined from 79% in the first 3 months to 42% at 120 months. So why is adherence a problem for patients with MS? An MS diagnosis changes a person's self-image, replacing a sense of health with identification as having an illness. Some patients find this so threatening they respond with denial. Diagnosis often occurs when the patient is feeling well, which may lead to questioning the risks of not taking the medication and the validity of a need for treatment which is intended to prevent future consequences.